resident of Sweetgrass County here in Montana in Big Timber. I have my master's in social work, and I am currently going for licensure for my LCSW. And I am the executive director of an organization called Catalyst for Change. Catalyst for Change was created and formed for rural and frontier Montanans, and specific to mental health. I believe the one thing that I would like to distinguish is the difference between rural and frontier, which I'm sure many of you already know, but just to clarify that. So in Montana, probably most people consider all Montana rural. We consider their—
Hey, Amber.
Yes.
Sorry, we're losing your audio.
Okay. Let me see what I can do here.
I said the closer you got, it kind of came back in, but it was starting to fade out.
Okay. Second here. So is that any better?
Yeah.
A little bit. Okay. I'll sit closer to the computer.
Perfect. Thanks.
Can you hear me now? Great.
Yep. Go ahead. You're good.
So the point of our organization is to serve primarily frontier Montanans first and foremost, and frontier Americans with rural areas in mind. One thing worth noting in rural towns and with rural residents, we rarely call ourselves frontier towns, so we consider ourselves rural Montana. So you'll hear us use both of those words, but it's really used to identify a population of people that are really spaced out between larger cities or towns, even in places like Montana. So we're housed in a small town called Big Timber. It's population about 1,200 people. And then there are a lot of neighboring communities around us, and we're in between two of the bigger towns or cities in Montana, known as Billings or Bozeman. And the nonprofit really started with a focus on mental health. And part of what we've struggled with here is accessing resources through regional facilities that are adequately serving our residents in a timely and accessible fashion. The reason we have, I debated whether or not we should do a PowerPoint or a specific presentation with slides, and chose against that. I thought hearing for you guys to hear from the people who are on the ground with me every day, working on the front lines to address a lot of the issues we see on a daily basis from different organizations would be more powerful. And with that, I will introduce each person of our organization to you so that you can hear from them specifically kind of what we do and how we do it. Afterward, I will kind of wrap up the different versions of what they're sharing with you and kind of show you how they all connect, and then answer any questions you guys might have. So again, my name is Amber, and I am the Executive Director of Catalyst for Change. We're in Big Timber. And the first person on our team I'd like to introduce you to is Dr. Mackenzie Kemper, who's a family nurse practitioner in a nearby town in Wheatland County called Harlow. She's one of our newer recruits to the team and very passionate about what she does. And the thing we're really hoping to show you guys today is how we've been able to address mental and frontier issues at the same time, mental health issues and frontier issues at the same time, and how we've succeeded in that over the past few years and where we see this going. So Mackenzie, if she'll go on here in a minute. I'll read you a little bit about her bio, just so you can learn a little more about her. So Mackenzie holds a doctoral degree and is nationally certified as a family nurse practitioner. She grew up in North Dakota, where she attended college for her undergrad degree. For graduate school, she moved to Colorado and completed a fellowship aimed at placing primary care providers in rural and underserved areas. It was this educational path and passion for rural communities that led her to moving and practicing in rural Montana. Together with the CHW team, meaning community health worker, in neighboring Sweetgrass County, our county, she's been able to bring mental health services to Wheatland County as well. Before I hand it over to Mackenzie, the thing that we really want to emphasize is the importance of a local community health worker in these frontier towns and how essential that person is to bringing quality, accessible, timely mental health services to these small towns in a way that we don't believe has been done before. So with that, Mackenzie, if you would like to go ahead.
Thank
Would
you,
you like me
Amber.
to take this slide down, Amber, or do you want to leave it up?
It's, whatever. You could take it down so we can see Mackenzie's face on a larger screen. Yeah. Maybe. No pressure, Mackenzie.
Can everyone hear me? You can hear
Yes.
me? Okay. I historically have computer issues, so I did several run-throughs. You probably picked up from Amber's introduction, not a mental health specialist. I'm a primary care provider, family nurse practitioner, working in a very rural clinic. We have a federal designation as a rural health clinic. Our community certainly falls under the designation of frontier. So it's about 90 miles to, sorry, shut off my phone for a moment here, 90 miles to any larger facility from us. So we're very isolated. We're not on a major highway. We're just kind of tucked into central Montana. And I think, aside from Alaska, maybe it's about as frontier as it gets as far as healthcare goes. And so when I started here about 1.5 years ago, we had very little, if any, mental health services, whether that be access to a counselor or therapist, any sort of crisis intervention. Where do you send these folks for medication management? The last time I looked at the national statistics, about 80% of people presenting for management of anxiety, depression, or any other number of psychiatric diagnoses tend to go to their primary care provider first. And so it's not uncommon for someone like myself to be treating these people, but sometimes I'm not the best person to do that, actually a lot of the time. And so I think if I were to choose one thing that this program has done for myself as a healthcare provider and the people in our community, is to easily connect them with the people that they need to be seeing. And so before this, it was sort of a haphazard approach to referring these patients to counseling or therapy, or to getting them in with a psychiatrist or a psychiatric NP for medication management. Now it really truly is as simple as calling someone on Amber's team, placing a referral. They always follow up. I have yet to see where the CHW in Big Timber or our new local CHW here has not followed up and gotten the patient what they've needed. And sometimes it goes beyond just simply connecting them with a counselor or someone to manage their medications. It might be coordinating a ride for them to a bigger area if they don't have transportation, which is really common in our community. A lot of people do fall at or below the poverty level. So having reliable transportation to get to some of those bigger areas, if we can't utilize telehealth for some reason, they will help them with that. It's kind of a coordinated effort between this central person, this community health worker, and law enforcement or school personnel or medical personnel like myself, where we realize that in order to successfully treat mental health, it's a whole person and a family approach really, versus kind of a fragmented approach. And so if you were to look at our county, Wheatland County, which is a neighboring county to Sweetgrass County, which really pioneered this program, if you compared us today to 1 year ago, it's a completely different picture as far as what we can do for patients who have mental health needs. And I 100% give the credit to Amber and her team. I've sort of just been an arm and an extension of what they've done. And if anyone out there is listening who feels like they could identify with being in a rural area that is underserved, which is kind of the definition of being in a rural area, I would strongly consider looking at what a program like this could do for you, because it really has improved access in a way that was lacking almost entirely, at least for us. So I think that's probably where you could pick up, Amber, if you have anything to add to that.
That's great, Mackenzie. Thank you. And so as you guys can see, this is one lens we're trying to give you from the view of a medical personnel in a rural area, and how we're able to help fill in some of the gaps regarding mental health services through hospitals, medical facilities, and different staff. We're working with nurses, with their administrative team. We work with every organization in whatever capacity we need to get them the services they need as quickly and timely as possible. The next person I'd like to introduce you to is Dan Tronrud, who was, and Mackenzie, thank you for that, by the way. The next person I'd like to introduce you to is Dan Tronrud, who has been here from the beginning. He actually started working as our first CHW here in Sweetgrass County once he retired as sheriff for 20 years here. So Dan is a lifetime resident of Sweetgrass County. He and his wife reside on the family ranch that his great-grandfather homesteaded over 100 years ago. Dan served as sheriff for 20 years and was appointed to the Montana Mental Health Trust Board by the Attorney General. After retiring, he was hired by the county as a community health worker specializing in mental health and addictive disorders. With that, Dan, if you would like to go, hear what you have to say.
Am I there?
There.
Am I on video or?
Yes, you're good to go.
Okay. All I see is Amber. Okay. As Amber said, I come from a law enforcement background. I also come from a emergency medical background. I've been a advanced EMT for a little over 36 years. So I bring to the table some coordination with different entities, whether it be law enforcement, medical staff, hospital staff, state, as far as when I sat on the Montana Mental Health Trust Board, to be able to kind of piece things together in a cohesive form. One of the things that is one of the things in small communities such as Harlow or Sweetgrass County is that law enforcement becomes the first responder unit for most mental health crises. And so without us having some kind of a end product to be able to transport individuals to or to follow up care, we did many years ago what was called patrol car therapy. You basically house the individuals until the crisis was over, and then release them and waited for the next crisis to come. It was very circular in nature, which really upset me. And so I went on kind of a campaign throughout the state to try to come up with some kind of a plan where we could help these people. These people are not criminals. They have mental illness and they need some assistance. And the worst thing that we can do as law enforcement is show up, put handcuffs on, and transport away. Our job is to help our people, not hinder them. And so that's what I started looking for. I started following through on the individuals that we would transport down to the larger facilities, let's say in Billings, to get some assistance. And when they were released, they would be handed a bunch of paperwork that they're supposed to fill out, and they're supposed to set themselves up with appointments. And some of those appointments, if you could get to them, were weeks, months out. That was not working. And so when Amber came up with this plan and what I saw coming through the state that we were funding through the Montana Mental Health Trust, this seemed to make the most sense that I could see. And basically what we do is we provide those people with some care. We help them when they come out of crisis. We help them get set up with doctors, therapists, help, whether it be food, housing, whatever, gas, to be able to get back and forth to their appointments. We became that individual that they could rely on and get some assistance. So the advent of COVID came along, and so did telehealth. Before COVID, telehealth was kind of looked at as maybe not working as good. You had to meet in public or in person first, and then you had to follow through with your telehealth possibly. A lot of doctors and therapists realize that telehealth is probably the way to go in the state of Montana. We use it within our school systems. We use it within our community, so these people do not have to travel out. It's because a lot of times, as Mackenzie said, they don't have the ability, fuel or dollars or something like that, to be able to get back and forth. And so we can provide that help and continuity in their care by using the telehealth system that we do here. Same way within the schools. They don't have to go outside the school. The school therapist or counselor will go in, bring the kid into their room, and they would go ahead and be able to hold their counseling session right there, never leaving the school. And so it's really helped not only in the health of those individuals, but the stigma, I guess you would have to say, of mental health. We have people now walking in our door because of what we've done, and basically saying, we would like some assistance. And so we can provide that with a smile on our face, and not show up as an individual that has to say, well, we can't help you there, you have to go somewhere else. We can provide those services. And as Mackenzie also said, we also provide transportation to and from food banks. A lot of these people can't carry groceries. They haven't got anything other than a bicycle to be able to go. And so we have a great food bank here in Sweetgrass County. And so we provide those transportation issues. We also go to larger cities for drugs that they're prescribed that our local drugstore can't pick up. And so we become that individual that if they need some help, they're not afraid to call on the phone. So that's what a community health worker is. In small community, law enforcement is that, but they're getting very busy. And so then that's where we stepped in to be able to assist. And I don't know what else to say other than I've enjoyed what I've done here, and the community has embraced it. So what can I do, Amber?
Sorry, can you guys hear me? Yeah, okay. No, that's great, Dan. Thank you. I think one of the things that's important to touch on a little bit before we go to our next speaker with what Dan is saying is, here we've had Sheriff of 20 years who's seen so many of the mental health issues at the local level. On the other side of it, it's on crisis. It's when they're getting incarcerated. And he naturally segued into this community health worker role where he's getting to work on the before they're incarcerated, before they get into legal trouble, do the preventative work, or if they have gone into crisis, catch them with follow-up care. And I mean, honestly, he's arrested many of the people that we work with, and they're okay with that. I mean, they trust him, and I think that really shows that the CHW is this trusted individual at the local level that people know. They know your face, they know your name, they know you understand them on a community level in your local town. And I think that's why we've had so much success in reaching a lot of our community here is we're not outsiders. They know who we are. That's why Mackenzie is helping it succeed in Harlow. She lives there. People know who she is. She's their family practitioner. I mean, it's really that trust, as many of you know, since we're all in rural areas or frontier areas, is everything. And it's the key to unlocking a lot of the stigma you're seeing in these towns is building that trust. I mean, there are a ton of empty telehealth rooms across the state. You know, people already struggle to talk about their feelings and emotions, you know, in these kind of more rugged communities, that rugged individualism of not talking about your feelings. The last thing they're going to do is go jump on a computer and talk to some stranger on a screen about their feelings. They already have a hard enough time talking to us about their feelings. So that's something Dan has done very successfully. It's been very impressive to watch and is also a very key component of what has helped our program succeed in reaching some of these more difficult populations to address some of these very serious concerns that we're seeing here in Big Timber. With that, we're gonna go to our county commissioner, Bill Wallace, who has been instrumental in the success of this program as well. Bill may not be on the ground like the rest of us are, but the things he does behind the scenes and the things he's seen over his many years as commissioner has been essential in helping people understand, you know, the importance of coming together as a local community and treating, you know, trying to address our issues on a local level and what we can do within our communities while not depending on regional facilities or nearby cities or towns. And so Bill, he has served as the county commissioner in Sweetgrass since January of 2011. He sits on both the South Central Regional Mental Health Center and Pioneer Medical Center Board of Directors and is very passionate about rural mental health. When he is not working as commissioner, he runs the Otter Creek Game Bird Farm, which he owns and operates in conjunction with his wife. So Bill, with that, if you would like to speak a little bit about what you've seen and what you'd like these folks to know.
Okay, thanks, Amber. Appreciate it. Again, my name's Bill Wallace. Are we working, by the way? Anybody hear me?
Yes.
Okay. Yeah, I've been from Colorado originally. Was kind of like Dan down there, had a cattle outfit, sheep outfit. And in '99, we decided to move to Big Timber, bought the bird farm, and it's been kind of where we've been. And I have a little personal experience with mental health in different parts of my family. And so that's why I'm kind of passionate. I know that in rural Montana, especially, we just didn't have any services or lack of services, I guess I should say. So back in 2017, the state cut funding, DPHHS, and it took our Department of Social Services out of the county annex. And what that did was really through the kind of the services that Dan was talking about and yourself, Amber, Mackenzie, back on counties to fill a need. And the only way to really do that was you come up with a program, and we kind of bought into it and decided that we'd get on board. So we started the budgeting process, and you know, we did have help with the DPHHS grants. A couple of counties, the 2 counties got that helped us out a lot. But we also ended up milling, I don't know, probably 3 to 5 mills of our own. And you know, it's not like you can just go out and do that. We had to adjust some things on one end to get to the other end, and but we managed to get it to start the program. Brought Dan on board after he retired as the sheriff, and I don't know, it seemed to has been working pretty good. We had a lot of, I sat on the mental health center board, but you know, a few years ago, probably 2 or 3 years ago, they come in and we have a meeting every other month, and they come in and all they want to do is talk about their numbers, not necessarily what they're doing for people. And I put my foot down one day and said, okay, enough of the numbers. What are we going to do to help people? I'm in the South Central Mental Health regional thing. There's 8 satellite offices, and you know, it probably does a pretty good service in Yellowstone County because that's where their focus is, but it gets really hard out in our county to even keep any type of a therapist in the office. And they end up basically being just something for the justice system to sentence to, I guess you call it, refer to. So that's all fine and dandy, but we ended up having people after Amber got started and Jessica Todd helping out a lot from the high school. You know, we'd have kids that, and that's where I'm coming from. I had kids that I know needed help, and those Amber and Jessica took her and other kids. I probably started out with 10 or 15 kids at the high school, and then their parents seen that they were getting something that weren't getting anywhere else, and it's probably exploded to, I don't know, 80 to 100 people now in our county that just come in and then we help them the best we can, whether it is a counselor or a therapist or telehealth, or ended up just helping them with that, like Dan said, medication runs or any of the other kind of stuff he was saying. So just very creative ways to enhance services that we didn't have and fill gaps in the state and federal programs that aren't being filled. And it's not like it's really easy in a small county, and I kudos to Wheatland County for jumping on board because, you know, money's tight. You have to be a little creative and borrow from Peter to pay Paul, but we've managed to make it work, and I think we'll continue to make it work. I don't know. I guess that's probably about all I got, Amber. Dan said what we needed was to be able for people to find an inroad to break away from the stigma of asking for help. And I think we're doing that. And I think Mackenzie would agree they're doing that in Harlow too. And it seems to be something that it's growing. I think there's a lot of people that I talk to in the different commission or groups around the state that they come and ask me, well, what do we need to do to start a program like yours? And Catalyst for Change is probably going to be that group that we would go to. And I guess with that, thank you for your time.
Thank you, Bill. Real quick, you guys, I'm in the office next to Bill and Dan, and I'm here. I'm being told that you can't hear me very well, so I'm just gonna jump right across here, and I will be right back.
No problem.
All right. Okay, I can read that one. Yep. Thanks. 1 second here. All right. Thank you for bearing with us during the technical difficulties here. So I'm glad you all got to hear from Bill and Dan. And of course Mackenzie too, but I think the next person we'll go to is Jessica Todd, who's our local high school counselor here. And she'll be speaking to some of what Bill was talking about. And then I can kind of wrap them all together, what we're seeing, what I see in the macro level change here. But ultimately our program really did start off here locally at the high school. And that's where we got the most buy-in, that inroad that Bill is talking about in the reduction of stigma started at our high school. And part of it was we came in very discreetly at the high school, and I was actually finishing an internship for my master's there working with Jessica Todd, who's the guidance counselor. And one of the things that we discovered that was very alarming and disturbing to us was how many of our kids were actually struggling. So we did what's called the YRBS, or the Youth Risk Behavior Survey, which I'm sure many of you know about, is a national survey on a broad array of things that kids are struggling with just to see where they are. And we discovered in 2018 that 30% of our kids had seriously thought about suicide. 30%, just to repeat that. And that 19% of our kids had attempted suicide 1 or more times. So when my practicum and my internship ended at the high school, we were left with these numbers, and I'm just supposed to go back to my schooling and just forget that I know them, and I couldn't really do that. And that's when we started grant writing. And that's when we decided, there's a problem here. We're discovering these issues. We're seeing what the problem is. And then there's really nothing we can do about it. There's really nowhere to refer these kids in an adequate way where the parents can reasonably get them the services they need without them missing a bunch of class or work. It was 2 years later that we then screened the kids again for the YRBS, and this program had been going off the ground. And we cut those numbers down drastically. So the ideation went from 30% to 26%. And the actual attempts went almost in half. So 19% to 10% of our kids had attempted one or more times. This was very encouraging for us. It told us what we're doing is working. And I think that's where a lot of the community buy-in has come in with our commissioners and all the people you're hearing from today, is you just can't deny that this is working, and you're seeing it in the numbers, and you're seeing it in the community, and you're hearing about it, and you're feeling it. So with that, I will let Jessica segue in here to speak a little bit about her experience in that way, and where we kind of started and where we are now, and where we hope to see this go. Jessica?
All right, can you guys hear me?
Yes.
Okay, great. So yeah, my name is Jessica Todd. I'm the school counselor in Big Timber, the high school one. And I started, my background's in education. I was a teacher first in high school, and then became a counselor, and I started here about 5 years ago. And that was one of the big issues that we had when I first started. Was I was seeing a lot of kids come in and presenting with suicidal ideation, struggling with mental health, and I had nowhere to refer them to. I had one counselor in town, and she was full, or very close to full. And so when Amber came in and was asking about how it worked, the program, just everything about the school counseling, we kind of really quickly identified that we just had nobody to refer them to. We weren't getting kids any direct services, and that was really hard for our students. We didn't have anywhere else to turn. There wasn't anybody else to offer any more opinions or advice. And so she kind of came up with this idea, and it started and kind of just took off. So it's, great. She's kind of got, there's a program, a list of counselors, things that we can refer to. We have lots of telehealth that's being utilized. We actually started utilizing that telehealth program before COVID. So last year when COVID hit, some of our students were still seeing their therapists regularly because they had been seeing them the same way in the school. So I'm able to refer students to therapists, and then we do a lot of coordinating with their class schedules so that they can see their therapist at school. That was another big issue we ran into at the beginning, was being realistic and having parents take their student from school to either Billings or Bozeman to see a regular therapist or psychiatrist or somebody. They would do it for a while, but the long term, it just wasn't happening. They would drop off, and then our students would be left with not having any services. So we were able to get them into seeing their therapist regularly through telehealth at school, and it just worked really well. So they would, they have a study hall or lunch period before school or after school. They would come in, and we get them set up, and they could visit right there at school, and they wouldn't have to leave. They wouldn't be missing a lot of school. They wouldn't be missing work and different things like that. And they wouldn't need, a ride to that Billings or Bozeman or someplace, a larger place that had more access. So that was one of our kind of things that we've learned. Privacy was also huge, which it always is, but students were really kind of private about that. And so we definitely, work through that. And as the years go on, it's seemed to be the students are understanding the importance of mental health more. And it's, I don't know if it's trendy, but kind of trendy that they have counselors and they have access and they know where to go to get the access to somebody that can help them. And so our students now come in and they're okay with other people knowing that they have a counselor, or they're okay with other people knowing that they need help. And our numbers have grown tremendously, and we have a lot more students seeing therapists and less students going and, you know, having some serious mental health or suicide attempts, or even ideation, because they've found that other students are visiting with these counselors and helping with certain issues that a lot of our students are struggling with. And so they're able to come to me, and we're able to get them set up with somebody, and we're kind of preventing crisis, which has been a huge help for me in my position, is preventing it before a lot of students are in crisis. Let's see. Yeah, so just kind of getting those direct access, you know, having that community mental health worker is also a great resource for me. I know a lot of us in rural health, there's maybe one school counselor for the whole high school, or maybe even the whole K through 8 or K through 12, and you just don't have anybody else. And so having that community mental health worker, you have somebody to contact and help with different situations, and a second opinion, somebody to kind of bring into, because not every student can relate to me, but having that other person, that other mental health worker, somebody to come in and relate to students that maybe I can't reach. So having that extra person has been really beneficial as well. Another thing that we've ran into is finances and fundraising and co-pays and helping pay some of that, because sometimes parents are a little hesitant about having their students see a counselor, therapist, somebody, because of the cost. And so assuring them that, you know, helping with that, and how that can be helped, you know, they can help pay for co-pays, has released a lot of stress of the whole process, and parents appreciate that. And it keeps the student, I think, in counseling for a longer time. They don't drop off as easy as they used to. So that fundraising and individuals seeing the importance of that has been extremely helpful for us. I think, you know, in the school system, as we have grown through this program, a lot of our teachers have really open minds about mental health. And I think when it started, there was obviously a little bit of less acceptance with kind of the program and what we had going. But as the years go on and our teachers are seeing how helpful this program is to those students, they are super supportive of any time that these students can see their counselor, they are going to make it work. And so that's been a huge, I think, kudos to the program, because they're seeing it in the classroom. They're seeing how much it's helping each of these students just in behavior. And so they know that it's important, and whatever they can do to help, they're on board with. So that's kind of been my experience with it. I don't know, Amber, if you have any. Obviously have a lot, but I don't know what else.
No, that's great, Jessica. Thank you so much. You know, I think just to touch on some of the other things with the school aspect of this is, we've heard from some different students why they think that this program works so well in our school. And I have a few theories. I think, one, Jessica's willingness and openness about mental health is so important. You don't see that everywhere, especially in these small towns, as many of you know. And so, you know, when we came in, we didn't hold an assembly. We didn't talk to the kids and the students about what we were doing. We were very, very discreet about it. And we kind of flew under the radar, and we were just there to offer services. It wasn't, hey, we're going to talk to, you know, all of you together about this thing, or, hey, we're going to offer you a training. It's, hey, you need help, we can help you with that. And one of the things that shocked me about what Jessica was doing at the school is, I've been in the field that I'm in is my MSW, my master's in social work, and having worked in crisis centers and mental health centers, I could not believe what Jessica was doing as a guidance counselor without any adequate training. It was unbelievable that she was carrying this really heavy burden of kids that are in serious mental health crisis, dealing with serious anxiety, depression, PTSD, just a lot of things. And I know that this is the case for guidance counselors in a lot of these frontier rural towns. It's unbelievable what they do. And so even when I was working with her in my internship, we were both so busy. I mean, I was in there every week, several hours a week, helping her in the beginning. And as we've brought in other practitioners, so therapists and psychiatrists in private practice or through the mental health centers or hospitals, they've been able to help carry that load. And that allows Jessica as a guidance counselor to do more of the work that she's trained to do. I mean, and for her, it's like, she's having to kind of juggle this thing that she's not really trained to do, but what option does she have? She's having to kind of almost be forced to practice outside of the scope of her education because of her location. And so, because of the geography of where she lives. And so I think that's for us where the fire was really lit, was at the school. And then it kind of migrated into the hospitals, and then it's migrated into the county. And I think why you've seen a lot of this success is the people we're working with, it's someone's niece, nephew, it's your neighbor, it's a relative of yours, or someone who's a good friend. And as you all know, in these small towns, everybody's kind of connected and everybody kind of knows each other in some way. So not only being sensitive to that, but also being very aware of that and knowing that when you're working with someone in these small towns, you're really working with an entire family or an entire community. It's never just the individual. And I think that's where it's been very encouraging for us to kind of take things into our own hands, where as grateful as we are to regional centers and facilities to be looking out for us, nobody can really take care of our own county better than we can. And the more help we can get from these regional facilities to empower us to become independent and remain independent and know what to do to take care of our own county, to know what people and dynamics work together and which ones don't, which is a very fine line. There's a lot of turf to navigate on a tightrope, and so it's not an easy thing, and it requires, I think the one thing I can say we successfully have mastered is working together as a community, even when we disagree. So maybe the priorities Jessica has at the high school might not be the case for law enforcement. It might not be the case for the county commissioners or for my organization, but where we're all willing to kind of work in the middle. And we're all kind of willing to meet halfway and negotiate where we can, because we know that overall it's for the greater good of our community as a whole. And I know I was cutting out a little bit before, so I might be a little redundant in some of the things I'm saying. I'm unsure what you guys caught earlier when I was speaking with Dan. But seeing someone who was sheriff for 20 years navigate to a CHW and be on this really vulnerable side where normally it's a more abrasive side that he's been working on, that's part of that is the community level. People know him, they trust him, they've seen him. He's arrested a lot of them. That's okay. People are comfortable with him because they know his face and his name, and that's enough in these small towns. I think, the main points I would like to send home with all of you before we open this up for Q&A is, the biggest piece of, I think there are a few things that have really contributed to our success, which number one is working together on a community level and locally. As many of you know, we've had funding pulled, I think it was 2017, where we lost a lot of the state and federal support that maybe we were used to for a while with social service agencies and stuff like that, case managers, community-based rehabilitation, those kinds of things went away. So then it, naturally fell on the local organizations to figure out ways to fill those gaps. So filling those gaps has been something that we've really focused on. The second piece is what Bill touched on, which is trying to find the inroad, so to speak, to reducing stigma. And again, that's back to when you start the school, we didn't hold an assembly, we didn't talk about a training. We came in really under the radar, incognito. One of our students said, we didn't, it was like probably some party all the kids were at one night, and they realized that they were all in therapy and they didn't even know it. And it was, oh, you're in oh, okay, it's not that bad. It's not that scary. And so before they would never talk about it. And now it's like this trendy hip thing kind of where the kids will come up to Mrs. Todd, hey, Mrs. Todd, can we get in the counseling program? Whereas before, nobody would even admit they were in it. It's also the same on the community level, you know, being able to tell the adults or the people that are in the community, not necessarily in the school, hey, you know what, you can work with us. You can come in the side door of our building. Nobody needs to see you. You don't have to walk down the long hall, you know, like the walk of shame type thing or something. If you see us walking down the street, you know, because I'm known as kind of the mental health person in town, I'll, you know, if you go like this and you don't know who I am, I'll do the same thing. That comforts people and allows them to let their guard down a little bit. So finding that inroad to reduce the stigma, I think is pivotal in the success of this program, and being called a community health department versus a mental health department, that makes a difference. The other two pieces is funding. So on the local level, you know, 80% of our clients are Medicaid. It's that 20%, the working class, who have really high deductibles, high copays, that cannot afford therapy and won't do therapy for that reason. When they find out that we have raised funding locally to pay for those services, I mean, we see tears of joy. Like they've been waiting for that and they could never quite get it. And now we've helped them fill in that gap. And then I think the fourth piece that is really probably 50% important as everything else we're doing is technology. And that's something you see in a lot of these rural towns. I mean, again, COVID's brought technology more into everybody's face, but we were doing this years ago. And there are not a lot of people who are comfortable on computers, have one, know how to use it, you know, or have access to Wi-Fi. And so us providing, I mean, we have, I think, 4 telehealth sites in our town, at the hospital, at the schools, here at the county building. We help people get set up at home so that technology isn't a barrier to keep people from getting the services they need. And I think other than that, you know, just kind of rolling with the momentum we've created has been the most rewarding piece and proves that what we're doing is working. And I think what I'd like to do is end with, one of our students was going to be here today. She had a delayed flight and could not make it, but she wrote something up that I'd like to read to all of you, and that later you can see on our website, which is catalystforchange.org, or you can Google Catalyst for Change, Big Timber, Montana. We did air on PBS NewsHour with Judy Woodruff, and her story is told there. But I will read to you what she wanted me to let all of you know today. So she says, hi, my name is Grace Folk. I grew up 45 minutes outside of my small rural frontier town of Big Timber, Montana, basically in the middle of nowhere. Growing up, I watched my father battle with bipolar depression and severe alcoholism. There weren't many resources out there, and drinking like that was very normalized. It was a long time before my father even knew the name of what he was fighting, and by then it was too little too late. I lost my father to suicide in 2016. It was my freshman year of high school. In these rural frontier towns, no one my age had a chance to learn anything more about mental health than what their parents did. There's a stigma here that makes it hard to admit you have a problem, and how are you ever expected to solve it if you don't? A little less than a year later, I was beginning to feel suicidal myself. I wasn't sure where to go. I couldn't even admit how I was feeling to my mom, not knowing what that news would do to her. So I went to the school counselor, that would be Jessica Todd. And unbeknownst to me, there was a new program at our school, one that got students set up with therapy from a nearby telehealth room. Right away, I was on a video call with Amber Blake. She assessed how I was feeling and got me set up with a therapist that I still see to this day. It is no exaggeration to say that the program saved my life, but it wasn't just me benefiting from it. After a while, students began to catch on. There were a lot of students receiving services, but by the time people knew, a lot of the stigma was gone. Eventually, even some parents saw what the program was doing for their kids, and it encouraged them to reach out. After I graduated, I was lucky enough to secure a spot working for the community health program for the county. Being able to be a part of this change has been incredible. I've seen this program save lives. I genuinely believe if there had been something like this around when my father was struggling, that he might still be here. Now I'm headed to college to become a therapist, to continue to fight for these changes, for the lives of rural Montanans, and for those across the nation without the resources they need. My greatest hope is that this program continues to thrive and grow, that it receives the funding and support it needs to grow across the state, and that it will still be there when I graduate. This program is the support that rural Montanans have been waiting for far too long. And with that, I will end our presentation.
Thank you guys so much. What an amazing program. Wow. We still have some time. I hope we can use these last 9 minutes. You guys can ask some questions of any of our speakers or raise your hand. We can call on you. I hope you're seeing the chat, Amber. You've got a lot of praises in there.
Thank you.
Just a real quick question, just to clarify, you said about 80% were on Medicare, and you said the other 20% you do private fundraisers for it?
Yes.
To kind of help with those costs?
Yep. We try to find support locally. And people are happy to do that because they see it and hear about it. So we recently received, for example, 25 grand from our local county Sweetgrass Community Foundation to pay for copays. And, you know, during COVID, we really went through a lot of that. And I would say we've used over half of it in 6 months. And I mean, that's for, I mean, we've reached probably in 3 years over 400 people in our community of 1,200. So that's how many people we are serving. And I would say probably little under 100 of them have been in private practice. Or I mean, sorry, using private insurance. Bear with me.
Gotcha. No, you're good. Brad, were you trying to ask a question?
Yeah, I couldn't figure out how to find the raise hand. Sorry. Did I understand somebody earlier on say that you do have some local property tax? There's a mill levy that's being.
Yeah, that would be a question for our county commissioner, Bill Wallace. I'm going to let him jump on. We're going to share. Oh, here, I'll just turn it here.
Yeah, hello.
Yeah.
No, we did not have a mill levy voted or anything. It's just we already had mental health designation in our budget and alcohol rehab, and we just added a few extra mills to those. By 3 or 4. That may not mean a lot to you guys. Our mills aren't like some places. It's only like 22,000 a mill, but we had moved that money around and managed to get these 2 programs furnished with a little bit of extra money so we could get started.
That's good. Yeah, and depending on where you're at in North Dakota, mill levies generate more out in western North Dakota and oil country than they do in other areas. So I can relate to that. So
Right.
thank you.
Any other questions, or anyone want to come off mute? Oh,
Matt,
Mary?
this is Mary. Thank you. I'm just wondering, what do you recommend for maybe other communities that are thinking about or have a need to go down a similar path? You know, what are some of the foundational elements? Where should they start? But I would also ask, you know, all of us, well, most of us work in a state office of rural health. Do you have any recommendations for us regarding, you know, how we might support rural communities that want to go down this path, or maybe sharing information or about your program? Just any recommendations that you have for us?
Absolutely. So I think to address some of the points that have been key to our success, it's necessary to find that inroad. So the hardest part of everything we've done is getting everybody to meet in the middle, as I'm sure many of you know. So in these small towns, it doesn't just, you know, you run into obstacles and you have to be able to navigate them. Just because you're getting resistance in the beginning somewhere doesn't mean people won't come around eventually. So I think in the beginning, it's key, it's crucial to find the players who see that there's a problem, that there are mental health needs that are not being met in these small towns in an adequate way that is timely or effective or accessible. And there are certain people who will be very passionate about that. That makes their jobs harder. They don't know how to fix it. So those people who see the problem, the professionals in the different settings, the people who are willing to address mental health and acknowledge it as real is key, because you just don't always see that. That's key. The other piece is funding. I mean, that's the thing that actually makes me the saddest. I did not realize, I never was a grant writer before this, and now it's like a huge part of what I'm doing with my team. I think for COVID, like COVID relief funds were huge for these small towns, because we got access to funding that was right at our fingertips, that was in our control, that we could have the power to do what we wanted with. I get calls from all over the state, different counties from across the state, that now that COVID's kind of subsiding, we don't have access to the funds. I mean, giving these counties direct access, funding it through your county commission or wherever you're going to get, you know, that support on a county level, where again, these counties know what they need and oftentimes are being covered by regional centers that mean well and try very hard to serve us. But, you know, having a therapist in a office Mondays 9 to noon and Tuesdays 1 to 4, it's just not gonna, it's not enough. It's not gonna do the preventative work or the follow-up care people deserve to get what they need for therapy, psychiatry, mental health reasons. So as you got, you know, for you guys in these state offices, really advocating, like I've tried very hard, and I've been successful sometimes in having others, of getting funds straight into our fingertips that we access, that doesn't have to go through another entity. It feels almost impossible. And that's the thing that's the most painful, is you can't do this if you can't hire the people to do the work on the ground. And you can't have, you know, access the resources you need. It's just, it's the funding's the hardest piece, and navigating kind of the politics and navigating that tightrope of reducing stigma, I think, are the big ones. Is that helpful, Mary? I mean, does that feel like, do you feel like there's something you guys in your role can do there?
Yes, thank you.
Yeah.
That's very helpful. Mhm.
Okay.
And I would say that, you know, these are issues that, well, at least in Idaho, that we hear about all the time, right? And I think what you've done is just remarkable.
Thanks. Yeah, and we are working on different projects to get a training and a curriculum. You know, it'll be a little while, but where you can always come to our website, check in with us. We want to see this replicated, and our goal isn't to kind of have a stake on any of these other regions, your areas. It's to help you become independent and run it on your own. You know, empowering these small towns to take care of themselves aligns so much with their culture. It's effortless after a while. So when I was with Mrs. Todd at the high school, I was there every day, several hours a week. And now we're in year 3. And this year I was there twice this year. Like, it takes care of itself. I don't have to be there anymore. That's the beauty of it.
Mm-hmm. Yeah, thank you.
All right, we are right at time. Amber, thank you so much for sharing this with us. This was amazing. Thanks to Jessica and to Mackenzie and Dan and Bill. And please do send a huge thank you to Grace for sharing that with us. That meant a lot to hear that. So yeah, with that being said, thank you so much for joining us today. And I can't thank enough to Natalie Claiborne in Montana for connecting us with you guys. This was brilliant. Thank you so much.
Thank you guys very much. Take care.